Good afternoon and welcome. I'm Dr. Razan Al-Arafa, Health Policy Analyst at the G20 Global Innovation Hub for Improving Value in Health. This session builds on Brazilian G20 presidency priorities for 2024 and follows a recent report produced by the Hub. The report explores how countries define, adopt, and scale value-driven innovation, particularly in resource-constrained settings, seeking to improve health outcomes and strengthening the health system resilience. Innovation is a term we hear often, but it's always not clearly defined. In healthcare system, the challenge is not just embracing what's new, but identifying effective, scalable, and aligned with real-world priorities. As we work towards stronger and more equitable health systems globally, we must ask, how do we define innovation? Who shapes that definition, and how we ensure it's translates into value for patients, providers, and systems? Health systems across the world are under increasing pressure, from aging population and rising costs to the growing burden of chronic disease and persistence inequities. The WHO estimates that by 2030, the world will face a shortage of 10 million health workers. Meanwhile, healthcare spending continues to outpace GDP growth in many countries, often without corresponding improvements in outcomes. In this context, innovation is often presented as a critical lever, but as today's discussion will show, countries implement innovation in different ways, shaped by their own systems, challenges, and reforms agenda. We are pleased to welcome our experts from Brazil, Italy, and England, each bringing unique perspective on value, equity, coordination, and healthcare. Before we begin the panel discussion, I'm honored to introduce our distinguished speakers. Dr. João Calero, writer, researcher, and health specialist at the Lehman Foundation Program, a comparative research and engagement program at the Convened School of Government, University of Oxford. Dr. Anat Yani, senior advisor at the Oxford Value and Stewardship Program and research fellow at the University of Oxford and the University of Heidelberg. Dr. Alice Alberini, a medical doctor with a public health background and a PhD in management focus on value-based healthcare. She leads the Office of Telemedicine and Digital Health and is currently implementing telemedicine projects and advancing digital health data systems in primary care. And finally, Dr. Reem Al-Bnayan, Executive Director of the G20 Global Innovation Hub and the leader in value-based healthcare movement. To open our discussion and help us reflect on how we define and measure innovation in a meaningful way, I'm pleased to invite Dr. Reem Al-Bnayan to deliver her opening remarks. Dr. Reem, the floor is yours.
Thank you, Dr. Razan, and I'd like to start by welcoming everyone to today's webinar. I'm very excited to be here with you. In the beginning, I'd like to say a couple of words about the organization. The Global Innovation Hub is an international organization that was established in the year 2020. When Saudi Arabia was the presidency of the G20, and the hub was created to accelerate the global transition towards value in health, an approach that emphasizes delivering better health outcomes at sustainable costs. The hub acts as a platform for knowledge exchange, experience sharing, producing important knowledge products to advance this conversation. Our strategy includes supporting the G20 agenda with data and policy input, producing evidence-based knowledge products, showcasing innovation, educating stakeholders, informing policymaking, and facilitating pilots and implementation efforts. We're proud to partner with prominent organizations like the WHO, the OECD, the Islamic Development Bank, the Harvard T.H. Chan School of Public Health, and Oxford University who we are here with today. All this is centered around a simple question on how can we move and accelerate health system transformation towards improving people's health and care. An important question for me to start with in today's conversation is to build on what we just heard from Dr. Razan on how we define innovation. Oftentimes, innovation is thought of as a way of developing new technologies or kind of digital innovations. But true innovation is not just about that. It's about what's useful and scalable in system transformation and novel ideas and approaches and partnerships to solve complex problems, especially those that affect value, resilience, and equity in health. At the Hub, we define innovation as a deliberate process of designing and implementing solutions that lead to better health outcomes, better person and provider experience, and more efficient use of resources. So it's not just about what is being produced, but it's about why, it's about how it's being done, it's about the experience of bringing it, and it's about who it affects. The distinction becomes critical when we look at the current challenges that health systems are facing globally. And this is the reason we need to shift and focus on innovation that is aligned with health system priorities, whether it's in primary care, whether it's in any care provision setting, whether it's in financing, whether it's in addressing more complex issues such as AMR. Importantly, we always emphasize that health and care is very local, and oftentimes solutions are context specific. And today's webinar really highlights that very closely. You'll be hearing from the esteemed speakers today from Brazil, from on Brazil, and on Italy and England, in taking different approaches to that we could learn from. And finally, let me emphasize that measuring the impact of these innovations is as important as applying them and learning from how they were applied in these settings. At the Hub, we are committed to supporting countries in identifying not only innovative practices, but on how to assess their value and how to think about the impact they have on their settings. And I'd like to make sure that I thank our partners at Oxford. It's been a tremendous experience doing this piece of work together with you, Joao, and colleagues in your team, and delighted to have both Alice and Anand as our speakers today. And with that, I'd like to hand over to you, Joao. We also call you JP for short, to brief us on this important piece of work. Over to you.
Thank you very much, Dr. Reem. Thank you, Razan, for the kind introduction. I'm going to be sharing my screen here. So my name is João Pedro, and I am a writer-researcher in the Lehman Foundation program at the Blavatnik School of Government in the University of Oxford. And our program started in late 2021, and it is a research and engagement program that is comparative in nature. So even though we have a big focus on improving the public sector in Brazil, we always look at it on a comparative basis. So with Brazil in the presidency of the G20 in 2024, this really gave us a valuable opportunity to highlight what were some of the findings from our research on health in Brazil, and what could be useful from that to other countries and the other way around. And this was the beginning of our partnership with the Hub that has been really very fruitful for us. So the name of the report that we're focusing on here is Leveraging Coordination and Promoting Equity, Lessons for Improving Value Across G20 Health Systems. So as you all well know, the health systems of G20 countries are very different in many ways. So you've got insurance-based systems, you've got taxpayer-funded single-payer systems, you've got private systems. But like Razan said in her introduction, they struggle with many of the same challenges. And when we were coming into this work, we were really trying to understand what were the common challenges faced by those systems. And coordination became one of the answers. So why coordination? Every system is needing to really respond to rising challenges with not enough resources. So what they all are looking for is, one, creating value, and two is really making sure that all the parts of the system are working in a way that you are able to achieve better outcomes with the same level of resources. So coordination became really the centerpiece of what these systems could do to get there. And another aspect that we really focused on was equity, which is also another concern that is present across all G20 nations. And specifically in the context of the last few years, coordination and equity have also been really challenged and heightened in the middle of the COVID-19 pandemic. So if you think about something supposedly simple that we saw in the pandemic a lot, so the infection boards, every day we would see those numbers that had the occupancy rates, you had the infections, you had the number of deaths. Something deceptively simple like that required every single institution in a country having the same standards, having the same way of processing data, sending that data to be processed for that to be reliable. So something that is as simple as that required an immense amount of coordination. And I think health systems across the G20 and across the world really coordination became something that they could not do without. And if you think about going back to the same image of the dashboard, you've got one headline number, right? But actually that number behind that was different groups being affected in very different ways. So if you think something as simple as the housing conditions that people were living in really affected their chances of being vulnerable, more or less vulnerable to COVID. So once again, both coordination and equity becoming even greater themes during the pandemic. And those things are also really connected to what we call advancing towards higher value health systems. And this is the headline phrase that we use a lot, the value for money, which really speaks to the more efficiency aspect of getting more from your resources, and value for many, which really speaks to making sure that better value is reaching better outcomes for different parts of society, and especially the most vulnerable. So throughout our report, we used two value frameworks that we referred to. So on the right here, you have the value framework that has been developed by Harvard University with the Hub, the High Value Health Systems framework with 10 components. So you go from analytics, value-based procurement, value-based payment models, performance benchmarking, and other aspects that really provide a guide as to how health systems can incorporate value within the way they work. But we also looked at a different framework here to the left, which is the EU Commission Value-Based Healthcare Framework that has 4 pillars that really also serves as guides for how health systems can approach the value premise. So technical value, we'll just go quickly. It really speaks to more of the efficiency aspect that we're looking at. When you think of allocative value, it actually speaks very strongly to both coordination and equity, because there is this idea that you need to spread your resources across different groups and be able to really visualize that within the system. And that needs to match health need. So this idea of allocation requires both the system to have coordination to be able to track that and to understand that, but also an idea of fairness in that distribution. And you also got personal value, which is it's a general idea that value of certain interventions is not something that can be just given on a number, because different groups are affected differently and might have different ideas of the value of those interventions, for example. And last but not least, societal value, which also become a very interesting idea to grapple with after the pandemic, because at the same time you have, of course, the social determinants of health that are very important. So that means, and that was very clear during the pandemic, that the health system itself cannot do all the heavy lifting in reaching better health outcomes. So other care sectors and other parts of government and society have just as important a role. And at the same time, the value of the health system in itself is not only related to health. If you think that having a functioning health system became the most important thing for something that the pandemic illustrated to governments, that health was the sine qua non kind of condition for every other type of policy. So with those connections between coordination, equity, and value, we looked at a few case studies in the world that really spoke to those ideas. So I'll just go very quickly here. I also encourage you to read the report, where we speak more strongly about all of them. We'll have Anand speaking more about the United Kingdom later, and Alici about Italy. But just very quickly, in the case of Argentina, for example, you've got hundreds of insurance-based mechanisms and that have very little communication between them. So how do you address coordination in a system like that? In the UK, we've got things like the recent reforms about the coordination of health with other sectors, other than value propositions being held at different levels. In the case of Saudi Arabia, you've got major reforms of the health system with value as a guiding principle, which is also a very interesting thing to understand. In Italy, a decentralized health system, you've got different systems that are meant to foster learning across the system, and that is something that we'll hear more about soon. And in Indonesia, you've got one of the largest expansions in universal health coverage in history. But universal health coverage is related to equity, but they are not one and the same. So the interesting thing here was to understand how to track the expansion of universal health coverage in tandem with the pursuit of equity, improvements in the health system. And a major case that we looked at was Brazil. In the case of Brazil, we've got a universal healthcare system that 3 in every 4 Brazilians use as their main point of care. And it is quite the achievement in organizational terms and in terms of the impact that the system has had in health outcomes since it was created in 1988. And something very interesting about the Brazilian case is that health is a shared responsibility between the three levels of the federation. So you've got the federal government, you've got 26 states and a federal district, and you got over 5,000 municipalities, which are ultimately responsible for delivering the health services. So 2/3 of these municipalities are quite small. They have less than 20,000 inhabitants. So this creates a lot of challenges for them in terms of getting the scale and the capacity and doctors also to deliver particularly medium and high complexity health action services. But there is a premise of cooperation and coordination built into the system. And one guiding principle in organizational terms is the regionalization of health. So what does that mean? Well, in principle, it means that the country is divided into health regions drawn by the states. And within those health regions, the citizens are expected to have access to a certain range of services. But that is actually not the reality, because citizens often have to travel very long distances for treatment, because you have and then it goes back to the headline idea: value for health, value for money, and value for many. You are not achieving value for money because you've got a lot of both waste of resources, duplication of services, and you're also not achieving value for many because you've got areas that become underserved, and you also got a lot of unwarranted variation in care. And why is this happening? So there are all sorts of reasons that we have identified in our work with health secretaries in Brazil and stakeholders. So, for example, the financing rules, the way the financing is working through the system, does not induce coordination. It induces fragmentation. The health region does not have the institutional backing and the institutional structures necessary. They don't have decision-making power. They don't have power over budgets. They don't have their planning instruments that would be necessary for the health region to really be the locus of the system. And you've also got political conflict between the municipalities that are bordering each other, and also between the municipalities and the state. But we've also identified that many states in Brazil have been able to really address this and to push regionalization as their own guiding principle. And this gave us also a few interesting ideas and recommendations. So one thing, for example, that we have noticed is that the states that have been most successful are the ones that are able to embed coordination and regionalization into their own organizational structure. So it's almost like they're mirroring what they want to do within their state, within their own organization. So if you've got, let's say, the organizational charts of this high-level political structures, they look very different from state to state. And the ones that focus on coordination usually do better. The other thing is that, as in the country as a whole, you've got institutions that, for example, there's an institution that actually predates the system called CONAS that gathers all the state health secretaries every month, and it's a place for them to learn and to also push for what they are seeing on the ground to get better. And this was also something that is a point of the system that is really working well, and not only working well, it was very important during the pandemic, because as the federal government did not seek this national coordination, those institutions really stepped in. And this speaks to also the role that COVID-19 had in Brazil as kind of a catalyst in a few ways for states to really take over this role in coordinating the system. And digital health also plays a role in facilitating this. So I don't want to get more time, but I would really encourage you to read the report. There's a QR code if you want to just get it now. And these policy recommendations that we reached in the report, they speak to some of these lessons. So this includes really looking at the role of these high-level coordination forums, the role of digital health in facilitating coordination and equity, and also in making sure that health equity frameworks and targets are created and monitored and advanced alongside the more classical measures of access that health systems are more used to. Thank you very much. I will pass it along to Alice now, who will speak a little bit more about the Italy case. That is a very interesting case that we also looked at in the report.
Hello, good afternoon to everyone. Shall I share my slides by myself? Okay.
Yes.
Can you see the presentation, right?
Yes, great.
Sorry, this is the last one slide. So let's start. Thank you. First of all, thank you for the invitation today. That's very interesting for me to share the Italian experience and to participate in this webinar. As you know, Italy has a national health services. It's founded on three main principles that basically are universality, equity, and accessibility. Of course, nowadays delivering healthcare services on this principle require navigating among demographic challenges and other important challenges of the population. So besides that, for tomorrow, Italy, as Joey was saying, is a system that is very decentralized. I mean, we have a national health services because it's funded by general taxes from the central level, but then the delivery and organizational care is at the regional level. So that's this is an important challenge that we are facing for tomorrow. So in this context, the Italian strategy in order to reach those principles and to assure a more equitable healthcare services is to implement and to measure at the national level of evaluation tools. Basically, we are implementing, we are experimenting, and we also have since a long time two national tools. The one is based on outcome evaluation indicators, and the other one is on performance evaluation system. And they help us to turn constitutional value into measurable and actionable improvements. As I was saying, this is we have those two tools. The first one is the National Outcomes Program. This is the oldest one. It was launched in 2012. This is coordinated by the agency that I came from, GINAS, which is the National Agency for Regional Healthcare Services. And of course, we work with the Ministry of Health, and the function of this national tool is to create a national observatory of healthcare quality of services. This tool serves as a continuum monitoring tool and as a strategic resource for system-wide planning and performance evaluation, basically. This is, as you can see, it is based on a national hospital discharge database, and it is measured at hospital level, but also territorial health services, local territorial health services. And these indicators cover a wide range of clinical domain, for example, cardiovascular diseases, oncology, mental health, and perinatal care. So it's a very wide tool with more than 200 KPIs. Since 2022, we measure annually those indicators, and a national study showed that more than half of the hospital identified as a low performing in 2016 has significantly improved their outcomes by 2021. So that's a very strong tool that we have at national level. Because this illustrates how performance evaluation can translate into measurable system gains. And we also have the other tool, that is the performance evaluation system. This tool is developed recently by GINAS. We are experimenting this tool since 2 years ago, 2023, sorry. And this is based on a broader organizational performance across 5 domains: access, care, processes, financial sustainability, investments, and also some outcomes. It uses over 150 standardized KPI indicator, and we use a different type of data. It's not only from administrative data of healthcare providers, but also, for example, balance sheet and other financial databases. Of course, unlike the national outcome programs, the performance evaluation system is designed for forward-looking governance. So it's more used at governance and at governance level, both regional and also hospital or local health authority level. Since, thanks to the National Recovery and Resiliency Plan, we are moving among another model, let's say, because basically with those financing, we established the National Ecosistema di Dati Sanitari, which is basically a national data repository of clinical data, administrative data, and also in the future personal data. And we think that this is the real challenge that we want to face, because in Italy we can't move from a decentralized model to a more centralized model. nowadays is very, very difficult and is not something that we really want. But the way we think that we can manage and we can improve our healthcare services is instead using measuring and performance evaluation system in order to see what is not going well, let's say, in our region, in our provinces, and work based on data in order to improve those outcomes. So this is the shift that we want to do, and this is the challenge that we want to face with the use of data that, of course, is in terms of investment, in terms of projectuality, is very, very, let's say, challenging. It's very important, but then we are sure that only with the use of data, also for secondary use, we can improve our healthcare services remaining public.
Thank you, Dr. Alice. Over to you, Dr. Anat, to share your perspective from England.
Yeah, thanks very much, Razan. I'm just going to share my slides. Can you see? Yep. Okay, cool. Let me just get into presentation mode. I'm going to take a slightly different and perhaps broader perspective on this word health, and maybe look at population health. So very briefly, just looking at the current state in England, as of March 2025, we have over 7 million people waiting to get care. We have continued decreasing life expectancy, which began in pre-pandemic, and that trend has continued. We have quite substantial increasing health inequalities across the population, and we have quite a dramatic increase in spend on healthcare as well. When I started working in the England Department of Health in 2011, it was 110 billion. 2019 pre-pandemic was 140 billion, and now it's 200 billion. And what we basically have is we're spending more taxpayer money and getting less health. So we are in a very, very low value state currently. There is a new 10-year plan being drafted for the NHS, which has 3 key shifts that are going to be the aim for the NHS in the next 10 years. The first is going from treatment to prevention. The second is going from hospital to community. And then third is going from analog to digital. I think all of these touch on some of the things that João and Alice mentioned. And very briefly, just looking at these strategic shifts, a lot of it really ties in and aligns with Jeffrey Rose's famous curve. So if you look at the population as a whole, and you look at the horizontal or x-axis, you have the risk of getting severely sick, low risk, medium risk, high risk, and then you have the percentage of the population on the vertical or y-axis. If you look at this orange bell-shaped curve, what Jeffrey Rose says is that most healthcare systems focus on these highest risk groups. These are the people with type 2 diabetes, obesity, overweight, high blood pressure, they drink too much, they smoke. These are the guys at the highest risk of a heart attack or stroke. However, what Rose says that if you look at aggregate morbidity, mortality, and spend, it's always in the bell of the bell-shaped curve, because though they're lower relative risk, there's a higher absolute number of events in the bell of the bell-shaped curve. Now, what Rose says is that if you want to shift the health of the entire population, you need to move the risk profile to the left. If you do not shift it to the left, it will continue drifting to the right. And as it drifts to the right, this red arrow above, the intensity and cost of interventions will continually increase. You need to do more and more for your population, and you have less and less health. What this statistics, what these kind of numbers demonstrate is that England is in that rightward shift right now, not a leftward shift. And with the new NHS 10-year plan, what we're trying to do is to catalyze this left shift. Now, in terms of coordination, what's interesting, what Alice was mentioning, and some of the stuff that João was mentioning, in England, we have a more kind of quasi-centralized system, and we actually have this data. This data is sitting, but we're not using it in the right way. So going back to the future, in the early 2010s, we had program budgeting information, Atlas of Variation information all published. And you could see, for example, you don't need to look at the details of these numbers, but this is just to indicate the sort of intelligence that we did have. For mental health disorders, if you looked across the population, which this analysis shows, there was quite a dramatic variation in spend, going from £407 per head of population as the max expenditure in one healthcare system to 134 in another one. This is in the same country, and we have this massive variation, and this just indicates the other variation that you could see. Now, when we have this central intelligence and we provided this to the system, what it allowed us to do was to engage in dialogue and discussion with the leaders of those systems to say what's going on, and then to also create this sort of coordinating network between the different healthcare systems and healthcare geographies so they can actually find out, you guys are doing this to actually optimize your care. That's why it's so low per head of population. I wonder if we could adopt that as well. This is something that we're proactively trying to integrate back into the NHS. We have the data, but we just need to synthesize it and publish it in a different way so that people can use it to actually drive more intelligent decisions. But what we are also trying to do, aligned with the left shift, is to actually look at what is truly delivering health. So disaggregating healthcare from health. And if you look at health outcomes disaggregated by length of life and quality of life, clinical care only accounts for about 20% of health outcomes. This is access to doctors, hospitals, nurses, pharmaceuticals, diagnostics. The other 80%, the stuff that's really driving our health, are these determinants: health behaviors, social and economic factors, and physical environment. And what we would like to do, and Zhao sort of mentioned this, is looking at an integration of all of the elements that can actually impact health, not just healthcare, not just the doctors and the hospitals, but all of the health choice architecture, which can dictate whether people actually have an opportunity to be healthy. So this is a fundamental question that we have in England right now. Does everyone actually have an opportunity to be healthy? And the answer to that, unfortunately, is a no. But we're not going to get that left shift, and we're not going to get these 3 strategic priorities delivered, and we're not going to be able to decrease the expenditure unless we actually account for some of these factors. So this is the last slide, but just some indicative examples. If we look at these 3 broad determinants: food, transport, housing, massive inequalities. So food, this quote is from a place in London called Tower Hamlets. Tower Hamlets has a childhood obesity problem. They also have 42 fried chicken shops for every secondary school in Tower Hamlets. Transport, if you're looking at the average London worker, they need about 44 minutes per day to commute. If you look at the people earning £200 to £600 per month, they need 54 minutes per day to actually pay for their commute. And if you look at people earning less than £200 per month, they need to work for at least 116 minutes per day in order to pay for their travel expenses. So you have these massive inequalities. The people that have the least have to pay the most. And then housing, as a final example, this is something that Zhao touched on as well. In the Brazilian context, we have the people in the lowest income quartiles having the highest number of housing problems. And therefore, they already have lower disposable income. And now a higher proportion of their income actually has to go to pay for these sorts of problems. And so this sort of just perpetuates these cycles of poor health and lack of opportunities to actually be healthy and well in our population. So with that, I will hand over to Razan, I think, and look forward to the questions.
Thank you, Dr. Anna. Thank you so much. So that, I think I have a question to start and open the floor with, to bring, all the discussion together and much of what we've discussed so far about coordination and how coordination, how we decide when it's worth investing more in coordination efforts, and how can coordination be operationalized in ways that avoid reinforcing fragmentation or inequalities. I would like to hear from you, Joao, or any of your or any of you.
Well, I can start. Well, in the reports, this was something that we needed to kind of grapple with right away. And one interesting thing, for example, is that the word coordination is the same word, at least in English, if you use for the process itself. So the coordination of the actors, and it is also the process through which you reach coordination as kind of this goal, this kind of horizon. So coordination is a continuum. You can, and it really depends on where you are placed in the system. So in some parts of the system, coordination might actually mean just increase communication to make sure that you're not duplicating efforts in reaching the same goal. So that is kind of a minimum idea of coordination. And if you think about something like a 10-year plan to improve the NHS, then it's really requires shared instances of decision making. It implies a level of coordination that will, of course, demand that people spend time and energy and money for that. So that has also its cost. So where you are in that spectrum will be very context dependent. It is kind of a decision on the costs and benefits and where those lie. And also in terms of your context, your health context. So we saw that in an emergency like the pandemic, the costs of not coordinating, and I think Brazil is also illustrates that a lot, just become immense and they kind of unavoidable. But sometimes the costs of not coordinating in a more standard scenario are not that evident. So also I think one of the points of the report is really looking at what you inside a system or the system is and is not doing, and for what reason, and what are the we encourage an analysis of those costs and benefits in the different contexts.
Thank you, Joao. Any of the speaker would like to build on that?
Yeah, I mean, I suppose I could take
Please.
it at a more granular level, in the sense that you know, the people have to like one another. I know it sounds kind of weird, but there can be some really weird cultures and toxic personalities sometimes, which makes coordination on paper, in theory, seem easy. But in practice, it could just raise your blood pressure every time you have to talk to somebody who is quite unpleasant. And I think that's something where you can kind of bring in the culture of organizations. And building a collaborative culture, I think, is quite key. And I think the people that are chosen to come into the professions, whether they be clinical or non-clinical, have to understand that as well. If you have this kind of overbearing top-down mansplaining approach to how things are supposed to be done in an organization, coordination is not going to happen.
So back to you, Razan.
Thank you, Dr. Reem. Thank you, Anat, for your reflection. Let's check if any of our audience has any questions. Okay, so we have one question from for Anat from Sarah. The shift that from treatment to prevention will add an extra challenge, coordination between different areas such as education, sports, and social assistance. How is England dealing with that? Thank you, Sarah, for your question.
Yeah, very interesting one. Heterogeneously. So England as an entity is, it's just like saying Saudi Arabia, right? So it's just, or even Brazil or even Italy. There are places in England where things are happening well, where those relationships exist and that communication exists as well. I mean, going back to some of the comments that Joao was making about coordination, this coordination also relies on relationships, right? And if you have people who know each other in the school, if you have a GP that is a school governor part-time and they have the connection with the school, and you have somebody else who's a surgeon who works in a food bank part of the time, or their spouse works in a food bank or one of these other areas, then you're starting to build this social fabric and connecting the elements. And when you have those relationships, they're not formal. It's not in your job description that you must do this, but you have those relationships and you start building those links within the community, then it's much easier for some of the coordination to happen. But if you have this mandate that you must interact with these individuals, and in one organization, and this is what's happening in England right now, that we have a lot of people coming and going. So we have massive staff cuts that are coming. In some of our organizations, 30%, some of the organizations, 50%. So when you have that type of churn of people coming and going, those relationships are really, really difficult to maintain, because in 6 months' time, the people will be completely different and those relationships will have been broken as well. So you have to reestablish the relationships. And then you just look at the logistics of it. It takes you maybe a month to get a meeting in the diary. You get the meeting, it's 1 hour, you come up with some actions, and then you have another meeting in, say, 2 or 3 months' time. So it's quite slow going. In some areas where that social fabric and the relationships exist, it's happening faster. In some areas where those relationships don't already exist, it's going much, much slower. There is no formula for this that we have, or that I've seen at least, apart from people just needing to make time coming together and then having some commonly defined objectives that they can work towards. And this again, I think, is also a source of innovation. To kind of touch back on one of the themes that Reem brought up, MDTs didn't always exist. And the need for MDTs wasn't very apparent, perhaps, for the surgeon who felt that, yeah, what I'm doing is completely correct. Who dares question me on this? But then over time, that need was demonstrated, and then the MDTs are now standard practice. So can we do an MDT for determinants of health, for example? And what would that look like? And how can we create it? And can we have that as a standard that every month the determinants of health MDT meets to discuss what's happening in education and housing and food and climate and transport and healthcare as well? It's something that I think we need to imagine and then just create. But we don't have any standard approaches to this yet. It's something that it's definitely a work in progress, but great question. I don't know if other folks have comments or other ideas in terms of how this can be done better.
Thank you, Anna. Please, Joao.
No, just very quickly, because it's something that Anand mentioned, and it is in a few of the cases. So talked about the spectrum of coordination, but we also got, and I think England's particularly in this idea of integrating health with other sectors, illustrates this tension between standardization. So you say, this is the expectation, this is the model you're going to use, and this is how you're supposed to do coordination. And the realities, the local realities, that some places were already doing way more than that. They now just have a certain model that they need to subscribe to, and that can actually have costs in the good coordination they were doing. And then you've also got the opposite side, when you've got people just mandated to do something when they are not willing to do so, and what is the actual benefit of that. And you've also got, especially in the Argentina case, where you've got a lot of fragmentation, but throughout the years and in specific moments, there were opportunities to say, actually, how about we do this a certain way and we'll provide an incentive for you to create this minimum level of coordination and standardization, and then over time you build on that. So you can also over time really build mechanisms for coordination with a soft touch and in a top-down way, because it is the central government doing that with the provinces and with the insurance mechanisms. But you can also do it, like Dr. Reem said, in a way that the top-down process and the bottom-up processes are both working and they're both being incentivized.
May I add something about our experience in coordination? I mean, I completely agree with all of you, because coordination is the main difficult part of the work. But in our experience, I think that with sharing goals with all the stakeholders is something that can help the coordination, because as Anand was saying, the coordination is very difficult within the same organization, and sometimes it's very difficult in the same office, let's say. But then when you engage all the stakeholders, the different stakeholders from different level of governance, different agency, different institutions, with the same goals and sharing the same shared goals, I think that the coordination is, let's say, more easy. It's not easy, but a little bit more easy. This is a reflection from my personal experiences coordinating all the national EU fund, the Next Generation EU fund that are involving a lot of different level of governance. And when you have the same goal at national level, so it's let's say easy to coordinate all the different parts, but is a very the very challenging work of the part of the work, let's say.
Thank you, Dr. Alice. Any other comments? Okay. So before we close, I would like to thank you all again for being here, and thank you so much for our distinguished speakers for such a rich and exchange of perspectives. Today's discussions help surface the announced ways coordination and equity shape the delivery of value, whether in centralized, decentralized, or transitioning systems. Through reflections from Brazil, Italy, and England, we've seen how structural choices, governance models, and incentives design all play a role in translating value-based healthcare into action. As a hub, our role is to convene and connect, creating spaces for insights like these to be shared, tested, and reimagined across borders. We look forward to continuing this conversation in our upcoming webinar, where we all will explore another critical dimension of high-value health systems. And we hope you all join us. For announcements or reading our knowledge products, please follow our LinkedIn accounts. Thank you all again for your time and thoughtful engagement, and see you soon. Take care.